Hey everyone, good afternoon. Great to see friendly faces I don't typically get to see. We will give it a few minutes for folks to join, but thank you so much for joining for the April monthly call.
Good afternoon, everyone. Always good to see familiar, friendly faces or names. Uh, our fearless leader is on a plane on her way to Hawaii for a conference. So good for her. Um, Almost on her birthday, nonetheless. Yesterday was her birthday. So uh, you're stuck with us. Tabitha and I are going to run today's meeting, but Lisa certainly contributed behind the scenes leading up to today. And so we'll do our best to fill her shoes, um, and then expect to see some pictures from Hawaii the next time we're all together. I hope we all get to enjoy that. Let me share my screen. I've got a slide deck to keep me on track here. Okay, how about now? Can you see MIECHV CQI slide number one?
Yep.
Okay, so a couple of things I wanted to point out, announcement wise, logistical wise, for the collaborative. Hopefully, you all know by now that we get to see each other in person in a little over a month. So, um, doggone it, I should have looked it up before we hopped on, but I think, is it the 29th?
29.
29th.
Thank you, Lisa. Thank you, Tabitha. 29th of May, we're all going to get together, this time in Tulsa. And our C1 partners in Tulsa are going to help us host that event. Thank you, C1. But we're looking forward to it. And we've been making preparations here, of course, on the CQI evaluation team. I know you all have been making preparations for your PDSAs in your monthly rounding calls. I just wanted to go through a brief setup of some of the things we'll concentrate on with respect to your PDSAs during the in-person meeting. Just a quick refresher on the SMART aims and some key takeaways when you're thinking about measurement. I know your focus up to this point has really been mostly on the SMART aims. This next rounding call that you have right before we get together at the end of May, we're going to start talking about measurement. And we hope to, of course, finalize some plans for measurement at the actual event. So more on that in just a minute. A couple of promos. Lasso will have a booth set up and be providing some refreshers about the services that they offer in Tulsa, Oklahoma County, and elsewhere. And they have some new folks who are part of our sustainment contract work that they would like you to meet if you haven't already. So they will be there in person, have a table, and they're also going to take the mic for a short period of time during our learning session. The last thing I want to mention is CCERT. So many of you, if not all of you, I'm sure are familiar with the CCERT training program. We're fortunate at OU to have right in our own backyard, just down the hall, some expert trainers in this methodology. So I'm familiar with at least one site tinkering with the idea of using engaging providers in CCERT training for your first PDSA. And it was one of the ideas that sort of popped in our head when workforce development was selected as a topic that, well, this might be something everybody could benefit from, and it's readily accessible. So uh, one of our expert trainers has kindly offered to travel with us to the event at the learning session. So this is just a brief promo. We will spend, I think it's 30 to 45 minutes, right? Tabitha? 45 minutes? Uh, with a brief rundown of what CSERT entails, how it might be beneficial to your program, and it's just meant to spark some ideas and food for thought there if you are considering that, perhaps not for your initial PDSA on this topic, but one of your future PDSAs. Okay. Anything more about that, Tabitha, you want to add?
No, no, I think you covered it, but we're looking forward to having them and hope you'll get a lot out of the overview. It should be pretty fun and interactive.
I guess for those who don't know, so CSERT stands for Components for Enhancing Clinician Experience and Reducing Trauma. And it's a secondary trauma training program developed particularly for folks dealing with behavioral health and behavioral and, in our case, parenting issues. So in at-risk environments. So um, that's the focus, and it's on the providers, right, not on the clients. And there's guidance there on how to work through trauma-related issues that you might encounter daily with the workforce, but then also how to address and mitigate secondary trauma concerns that you might encounter as a provider. Okay, really brief refresher on Smart Aims, but with a month to go before we get together, I've seen everyone's ideas at this stage so far. Lisa's been documenting that for us and sharing it on paper. Uh, the plan ahead, and she's going to cover this with you in the upcoming rounding call, and then of course we'll have a deep dive when we're together the afternoon of the learning session, is to craft your change ideas into SMART aims. SMART, of course, is the acronym for specific, measurable, achievable, realistic, and time-based. And all of this you already know, and you're experts now on building SMART aims, so I'm not going to preach to the choir. I did, though, want to point out the fact that this go around may be very different than what we've done collectively as a group in the past. So I mean, I'm going to highlight this for the SMART aims and then for the measurement on the next slide. I've changed the examples in this old slide that I dusted off from early MIECHV CQI learning sessions and inserted some ideas that I saw listed on paper with Lisa's documentation. So what do we want to change this go around? Well, it might be something as simple as our own understanding, right? Maybe all we want to know in this first PDSA is what are the workforce issues of greatest importance to our current providers? I think that's totally appropriate. And frankly, you know that we're also working on this coordinated state evaluation in parallel to your CQI network. And that's something we want to learn. So we're going to be looking at that as well. So I think that that's totally appropriate, although clearly sort of a deviation of what you have done in the past, right? You're not necessarily trying to change something about the direct interactions of providers with clients. We just want to learn from each other about what is it like to be a home visitor. So step 2 on this little guidance of developing your SMART aim, what do you want to change? Well, it could be, let's develop a list of our top 5 perceived concerns and maybe even strategies to address them. I think that that would be an appropriate, feasible, meaningful PDSA for this first cycle. How much do we want to change? Here's where we got to kind of think out of the box. Again, a bit of a deviation from what we've done in the past. And this was my weak attempt at trying to do this on the fly about an hour ago. Well, maybe we want to achieve consensus, right, on what those issues are, and also on how we mitigate any of those concerns. When do we want to do it? This part hasn't changed. So we're going to do a 6-month PDSA, I said cycle, I should say phase, right? So we're going to do 3 phases as we've always done. They'll be roughly 6 months apart. So you'll have, depending on when you want to activate it, 5 or 6 months to work on each one of these. But again, that part hasn't changed. Who do we want to focus on? I think this is different than the vast majority of the PDSAs we've done together in the past. And I would suspect that for most of you and all of the smart aims I can recall reading, the focus will really be on your provider workforce and less so on your clients. Okay, so I'm maybe stating the obvious there, but I wanted to get through that and sort of like allow you permission to think outside the box. And if you're struggling with, oh, how do I develop a smart aim around a survey internally to figure out where our concerns are, we're expecting that, and you certainly have that license to deviate off the old script. Sort of more of the same here. I don't have it documented, but this is the old slide. But I think it needs to change for many of you, given the focus of your upcoming PDSA. So although we still believe that for rapid cycle testings within this COIN framework, PDSA framework, numerous, fast, fresh, and frequent measures are ideal, it's not a great fit for some of your PDSA. So again, just permitting you to think outside the box here and sort of deviate from that old script. I don't know how often you want to be surveying each other on what your top workforce priorities are. Probably not more than once, and I think that's fine. So it may not be numerous. Now, revisiting the responses you get for that, I think probably ought to be a little bit more in-depth and involve some recurrence, right? Maybe you're working on developing strategies or even developing consensus or coming to consensus on what the top issues ought to be for your future PDSA work or your future quality improvement work. And that may not be fast. That might be your entire 6-month cycle here to work on coming to a consensus and then developing, like a mini strategic plan of how we're going to improve upon current state of affairs. So this is the old slide. I know that we've kind of stuck to that historically, but again, this seems like a different animal. So we're going to be a little bit more lenient on the types of measures that you develop. We want it to be a good fit for your project. The other thing I want to plug here is we're ready to talk about measurement. So I don't know how often that's come up in the rounding calls to date, but Lisa is going to touch on this next month. And per usual, we'll do a deep dive in the learning sessions. We will have all the analysts with us. We have fewer analysts this year than we have in the past. So I think every analyst has at least 2 programs. That's not terribly uncommon, but some actually have 3. And so forgive us, but there's going to be a lot of hopping around in your afternoon session next month of analysts in groups. But when they show up, we're asking them, let's concentrate on measurement. So understand what the group wants to do on the measurement side and then provide any advice or guidance as you see fit. So just fair warning there that you're going to get a little bit more limited time face-to-face with your analysts in the session next month than our learning sessions in the past. Okay, I mentioned the coordinated state evaluation, and I expect to hear from us, about this on all of our monthly calls, and I'm going to report out some highlights of a protocol that we're developing at the learning session next month. That work is underway, as you know, and I'm going to repeat myself a little bit, but I think it's good to cover this ground multiple times for awareness sake. In the coordinated state evaluation, as that name implies, we are working with other states on the same topic of workforce development. In fact, there are 7 of us, so 6 other states besides Oklahoma working on this topic. We were charged with coming up with 2 broad questions that we all pursue simultaneously. And last month, or maybe the month before, we finally settled on what those 2 ought to be. Those are the first 2 aims that you see here. So I think I gave you a tentative version of this on our last monthly call, but now it's set in stone and we're moving forward, and it's in the protocol already. And we're building out our research design around the aims that you see in front of you now. These first 2 are the ones that we agreed to share. Aim 1, identify, describe workforce support strategies used across Oklahoma's MIECHV local implementing agencies to promote professional well-being. So it's shared with the other states. They're going to plug in their state name, not Oklahoma, of course, but we're all going to pursue this locally, and then report back what we learn, and look for alignment and maybe uniquenesses. The second, the other thing I'll say is, like all group work, sometimes you got to make compromises. And we didn't get to choose the exact wording of this one, so I'm not 100% thrilled with the term strategies there. And the work that we have planned on our protocol is not just focused on what I would view as a strategy. I mean, we're thinking of workforce supports very broadly. Everything from, I don't even know if these exist, but like financial incentives for going above and beyond, or even non-financial incentives for going above and beyond, to the nature of how supervision works within your agencies. These may not be strategies per se, but whatever supports exist that we think are connected to professional well-being, we want to study. We want to document them. We want to know how often they occur. And then we want to hear from your providers and from you about which ones you think are most effective at moving the needle on professional well-being. So that's aim one for us. And I think most other states too. All right, aim two, examine associations between workforce supports and professional well-being. So aim one is really qualitative exploratory. Let's find out what exists present day. Let's find out how well these things are working, at least from a perception standpoint. Aim number two is like where the rubber meets the road. All right, of these things that exist, or maybe some new ones even that we implement during this process, how effective are they at affecting or impacting professional well-being? So that's aim two, and maybe the more exciting of the bunch here. But we're really eager to see how workforce support variation across your site's present day might be associated with professional well-being. And maybe what we learn is, hey, here's a support from only two of these agencies, but boy, those are the two that seem to have the highest level of professional well-being. Maybe this is something we ought to disseminate more widely. So that work is definitely on our docket for the early years of this CSE project. In the later years, we fully anticipate trying to convince at least some subset of you to adopt a support that seems to hold some promise so that we can say something a little bit more globally about its impact. Maybe that's something like CSERT training, if we can get more than one site to do it.
David, I have a question about these questions. Are these going to be part of the discussion in person, or that's going to be, the work that we're going to get, outcomes when we start implementing our first cycle?
Yeah, great question. Good segue too. I'm going to repeat myself in a slide or two because I have a version of an answer to that. Each one of these aims we're going to attack slightly differently. Aim one will be heavily qualitative, and our plan is to do individual interviews just because they seem to be more convenient for you and for us. We thought about focus groups, but it's really hard to get everybody there at the same time. But probably a virtual interview over a Zoom session, HIPAA compliant, privacy secure. And then undoubtedly we'll be doing some surveys. You're going to see in a slide in just a moment, we are charged with collecting a common measure on professional well-being. That measure has now been selected, so we know what it is, and we have to convince you all to provide us some responses on that. So I'm going to show you some example items of that, of those measures, or it's really an item set, I should say, that were selected as a group that we want to gather from all states. So brief surveys, qualitative interviews. We will look at administrative data, so things like how long are the providers staying with the program, retention. That's going to be an outcome of interest. We have to, in this project, I love it, but it's a little unusual. Because this is a fairly long project timeline, I mean, we'll have a little over 3 years after we submit the protocol next month to complete the work. The expectation is that we have lots of details in there about what we want to do next year. But the year after that, we can be a little bit fuzzier. And every year, usually in January, I have to submit an amendment with more specifics about, okay, this is what we're going to do this year. So what we're planning to do is strongly leaning in the direction of qualitative work for the first year. Some of those brief surveys, but the majority of it will be qualitative data we gather from you. And then in the second year, things may change a little bit, and it will depend on what we learn and also what collectively the other states that are working on this want to do as we approach these common questions. The second aim, more surveys there. The third aim, surveys and interviews again, but with clients and not with providers, not with supervisors. I didn't mention the third aim yet, did I? So this one's unique to us, although I do think it sounds like at least one other state and maybe two are also going to pursue this, but they're not required to. But we're really interested locally in, all right, does professional well-being translate to improved outcomes of the clients, right? Which we always sort of should be paying attention to, of course. So we're interested in whether or not professional well-being is associated with client retention. We've been making this subtle distinction between program visits and retention and then engagement. The idea being that, well, just showing up to a visit doesn't necessarily mean you're fully engaged in the program. So the work we're doing now, we have some new ideas on how to measure what we're calling active involvement in the programs. And so we're really interested in this new work as to whether or not professional well-being is associated with active involvement. So those are the types of questions we hope to answer with the third aim. As we're gathering all this data, as we're learning new things, you will be the first to hear. And in some ways, maybe even a guinea pig, forgive us, but captive audience. And we want your input. We want to make sure that what we're hearing and interpreting is accurate. So you'll be hearing a lot of this in monthly calls in the future as the data starts to pour in. And it's designed intentionally to be complementary to the work that you're doing on this CQI network, also focused on the workforce development issue. All right, as promised, measurement. So item set has been selected by the whole coordinated state evaluation group. And these are examples of items that we are tasked with collecting. Our plan is to first unveil this at the learning session. And we're going to spend the brief introductory moments with filling out a REDCap survey that has these items. Our hope is to get a baseline understanding of where professional well-being is today. Moving forward, you can expect us to try to do something similar, most likely at a learning session, since you're there, we're there, and we've got time built into the agenda to do that data collection, because I know it's onerous, and the last thing anybody wants to do is more paperwork or more data collection. So to inform both the CQI network, but also the coordinated state evaluation, we're hoping to embed this within learning session content. To the extent we gather some qualitative data around this issue too, we'll try to piggyback off of our other encounters with you on rounding calls. So try to limit any extra, at least time commitment to gather the data we need to gather. Right, I don't think I left anything off of this. Yeah, so qualitative interviews, brief surveys with providers, those are definitely going to happen for AIM 1. Brief surveys with providers yet again for AIM 2. This is likely to happen in later years. I don't know that we're going to do a whole lot on that in the first year. We really just want a better understanding of what are the workforce supports that are in play. Then we'll go attack this question of which workforce supports can actually move professional well-being. And we'll be looking at some administrative data for professional well-being, as I said before. Retention of your workforce is an outcome of great interest to us, and I imagine to you as well. AIM 3, qualitative interviews, brief surveys are kind of the bread and butter for that one, but with clients. We'd love your feedback on this now or in the future. So if you have an idea of questions we ought to be asking, or even methods that we ought to use to gather the data, please do not hesitate to provide us input. I've left some details off, and some of these are still in flux, but I've got qualitative interviews here. we are thinking of qualitative data collection a lot more creatively than we have in the past. And so Tabitha has the great idea, which I think we're going to follow through on, of using photo voice. I don't know how many are familiar with photo voice, but rather than just rely on our classic Zoom session for a qualitative interview, we thought it might be interesting to see if providers are willing to take a photo of something in the workplace to the extent that they're permitted that describes their well-being and then provide that back to us. I'm skipping some of the technical details there, but photo voice is a way for individuals to communicate not only verbally but visually with us through the use of photography. So more details on that coming, but that's almost certainly one of the ways we hope to capture some information on AIM-1 in year one. Okay, I think I'm going to turn it over to Tabitha now, and you're going to get a brief update on our ongoing work in family engagement with our Health Access Technology Survey.
Thanks, David. So I know this project has fallen by the wayside in terms of updates. I want to bring it back to your awareness. I'm going to share more of a kind of a gentle reminder of what we're up to, but at the learning session, we'll provide a little bit of a deeper dive of the status of this project. This is kind of the final push with the engagement work. We previously referred to this project as health equity. So please be aware that the language we're using is health access, and then there's this technology piece. So first we'll remind you of what even research questions are we asking. So in the area of health access, I know the slide is busy, but there's a lot we're interested in terms of how families might experience their ability to access health and what affects them to be able to do that. So we are exploring the distribution of perceived health and social care equity among our home visiting eligible caregivers. We're also exploring whether there are differences in that perceived access, that health and social equity among folks we consider to be strongly engaged when they were in home visiting, those who were weakly engaged with their home visiting, and those who were eligible but were not clients. So those are our three groups. To remind you, we have a particular kind of cutoff point on what defines strong versus weak engagement. It's based off attendance at their home visiting sessions. So we have a group of those who've been identified as strong, those who were weakly engaged, or in other words, did not attend many of those meetings. And then our non-clients, as of right now, are being recruited from WIC rosters, so folks who might qualify but have not utilized home visiting services. Next, we want to understand the relationship between their perceived equity and their referral status, meaning have they received referrals for health and social care, and then did they actually utilize it, depending on that experience. We're also looking at the potential relationship between their perceived equity and treatment and the health and well-being of their family. And another interesting one we're looking at is how will the predictive strength of that perceived equity kind of line up with geocoded equity measures. So what we mean by that is we're looking at where they are in location and what they might be able to access close to where they live. Question 6 relates to that as well. So when we look at home visiting accession maps of people who are utilizing it with these health equity metrics, are there any areas where we serve that we would consider a home visiting desert, meaning that they can't easily geographically access this service? And are there other areas that are high deprivation areas? So those are our health access research questions. I know that's a lot of language. Any questions, thoughts, reflections at the reminder of these questions we're exploring? Then we also tacked on a technology piece. So just three more questions here. We are interested in how engaged the folks we're meeting with are in utilizing online parenting resources, what their attitudes are toward technology, especially using technology in early childhood programs or for parenting, and what do they consider are trusted sources of information for parenting advice. So to break down how we're going to answer all those questions, we wanted to remind you what we're actually asking of our folks who are engaging in this survey. So to help us understand health access, we're asking their location. We're doing that with their zip codes. We're asking about their comfort discussing the questions and concerns they have with the service provider. For those who utilized home visiting, it would be about their home visitor. For those non-clients, they're able to select any other type of service provider they've gone to for behavioral health care for their family. We're also asking about the perceived cultural competence of their service provider, so how well their provider kind of understood that family's culture and respected it. They're also, for those who have been in home visiting, they're reporting on their own engagement in it. So we have some questions about why they enrolled and their overall experience with their provider. Then we're also digging into some possible experience of discrimination based off their own or their family's characteristics. So some examples, we're asking if they feel they've ever experienced discrimination when accessing healthcare based off the language they use or their level of education. And that's across settings. So in home visiting, school districts, dentists, a few others that they're commonly encountering as they care for their families. And then last, we're asking about the frequency of discriminating experiences in service settings. For that technology piece, we're asking about sources of parenting advice, and specifically for those sources, how helpful are they or useful? We're asking how often they do use online resources for parenting. So as just an example, how often might they look up family-friendly events online? Or how often do they use technology to access information about their child's school? We're asking about their attitudes toward technology use for parenting support. And last but not least, their willingness to use a parenting app as another tool in their toolkit. So brief recruitment status update. We need a complete data collection this summer. This is a project that will end in September. We are still awaiting back translation to offer this survey in Spanish. So we've not yet reached out to folks who are Spanish speaking, but that is underway. It's already been translated. Now we're doing the back translation process. So far, everyone we've met with is English speaking. And this is a visual. If you're able to see that, the orange or that top bar is showing you our goal recruitment. We're hoping to meet with about 50 folks in each of those three groups I talked about. And then in the second line below that in the blue is where we're at. So we've already met with sufficient number of folks who identify as strong engagers. So those who did engage in home visiting and did so at a high level. And then we're about a quarter of the way there for our weak engagers and have just kind of launched reaching out to those non-clients.
Sorry, I may have advanced one too many there, but any parting comments on the health access or technology survey, Tabitha?
I think that's it. I hope it's useful to be reminded it's happening and where we're at with that. At the learning session, again, we'll give you a bit more rich understanding of where we're at. We look forward to reporting out on it in the fall.
Yeah, wonderful. If only so that you're alert that we're still contacting your clients for this survey. We thought that this would be beneficial. And yeah, we're excited about the findings from this. And just as I mentioned for the new workforce development group, you'll be one of the first, if not the first audience to see the results when the survey nears completion. All right, I had one more item on the agenda today. I wanted to give you an update on our care coordination sustainment project. We haven't always called it that, but that's what we're sticking with from now on. This is continuation of the innovation project that you participated in the last 2.5 years, 3 years. Of course, the funding ran out last year, and we tied up some loose ends toward the end of the fall, beginning of the winter. All the while, we were talking to our partners at the Oklahoma Partnership for School Readiness about securing some funds to sustain the progress that was made. And fortunately, they were able to provide that assistance. So we are moving forward with some components of that innovation project. I know you've heard us mention this in past monthly calls. I thought I'd give you an update on present activity for this calendar year, and then put in a plug for the work that's ahead. And you're going to hear more about this also at the learning session in May. First, a reminder, Project Focus. So we're sustaining and hopefully strengthening referral coordination that was originally developed under that innovation award. We have 3 supported staff working on the project, what we're calling now a home visiting care coordinator. This is Elizabeth Bankhauser, previously our Sooner Start care coordinator. Sooner Start has, their role has lessened in this sustainment project. We definitely want to continue to focus on referral traffic of developmental services, and Sooner Start is engaged in that conversation. But we're really transitioning Elizabeth out of the offices of Sooner Start and into your home visiting agency offices, at least in a virtual fashion. More on that in a second. LASSO continues forward as it always has been, with the exception of Unite Us. I know is a little bit trickier. Hopefully, we're all aware at this stage that to get the prioritized access to LASSO, when you submit their Unite Us form, you have to put the term MIECHV in the note. And if you put the term MIECHV in the note, it comes to Pilar's attention and she will expedite it. They are open to other types of referrals. You can call, you can, I think, email, and they even have a fax machine, although it sounds like they're reluctant to use it, as you are as well, I imagine. But it is a possibility if you're restricted to that modality. Community Outreach Coordinator, this is LaShonda Stevens Sotomay, just a continuation of what she has done during the innovation project. So one of the things we wanted to plug and promote is that through this sustained funding, LaShonda is here to help us with the communication of network partners. So it could be with LASSO, although you have a direct line to Pilar as well. It could be with Sooner Start. It could be with other developmental service providers. Those are going to be our main targeted areas. But if there's another outreach group where you feel like the referral communication could be improved or the relationship could be improved, that fits right in scope with what we're hoping this outreach coordinator can accomplish. And she's got a lot of experience at this. I don't know if she's on the call right now. It feels strange to speak for her in this way, but she's excellent at making connections with our group on the clinical and training side at the university, and certainly on the evaluation side. So we're hoping to extend that same talent and communication effectiveness here for the sustainment project. Emphasis on developmental service referrals, legal support, and system improvement. That really is our focus. So broadening our horizons beyond Sooner Start, as I said a month ago, to any developmental service. So not restricted to just kids between the ages of 0 to 3. I think that's important to emphasize here. And we're open to the possibility of exploring other referrals, particularly if you feel you're struggling with a kind of referral. Let us know, because we think there will be wiggle room here for us to tackle some other topics beyond developmental services, legal support. Key activities, as I said, LASSO is kind of continuing on as they have before. They had, for our last quarterly progress report that just went in a couple weeks ago, 28 legacy cases from the innovation project that they were still working. 8 of those closed in that quarter. And then they received 6 new referrals from your agencies. Two of those had already been accepted by the time I sent that report in, but they were working on the other four. Timing of the referral process is something we want to be better at documenting, particularly during this sustainment process. So that's one of the tasks ahead, particularly for Pilar, who is acting as the care coordinator for LASSO, and then for Elizabeth as the care coordinator with your home visiting agencies. We're going to try to amass as much data as we possibly can on timing, whether that's in structured fields, like automated timestamps of your referral tracking forms, or maybe it's stashed away in an unstructured note, which we know it can be. She's going to pull that out, aggregate it together, and we're going to try to do put our best foot forward here in terms of trying to put timing metrics on the referral journey. So how long does it take after the referral is made for the network partner to actually contact the family? Do we have any information on that? And if we do, how long did it take? How long did it take for an intake session to be completed? How long did it take, if they were eligible after the intake, for the intervention to actually begin? So these are types of timing things we're going to be looking for in the referral tracking information in the ETO system. And we will supplement that with information that your network providers offer us in return when asked. You may be asking yourself, as I do as well, what if that information is not present? Well, I suspect it won't be for many of those cases. And what we plan to do is build dashboards with individual cases documented with missing time information. And we want to have an open conversation with you about what would it take to fill in these gaps of knowledge so that we could be monitoring these timing metrics more universally, more systematically. In the learning session next month, Elizabeth and I have a brief session or a brief agenda time period to share back some of our, I'm not sure whether to call it quantitative or qualitative, but we're going to go into those charts in the ETO system and try to pull some of this information back and then share some examples, some anonymized examples with you, and troubleshoot on the fly together as a group about where improvement might lie.
I have another question. All these child developmental referrals are based on the ones that we have done the score, maybe a positive screening, and we had done to Sooner Start or other like child find, child guidance. I don't know if you have that information.
We will be looking at child find and child guidance in this work that's ahead. So that has just begun. We're at the early stages of that, but absolutely, we want to broaden it beyond just Sooner Start to include any of the other developmental services that you're referring to commonly.
Dr. Bar, just to clarify, so any LASSO referral will still continue to be through NIDAS?
I don't know if Pilar is on today, and if she is, she can correct me if I'm wrong.
Or just direct email to her, just saying this is my MIECHV client?
Whatever your preferred approach is, they're fine with that, as I understand it. The Unite Us pathway does still exist if you've got access to Unite Us. I learned, I think for the first time a month ago, not everybody still has access to Unite Us, even if you're a nonprofit agency. So you can make the phone calls, you can send the emails. Those are just as effective if you use Unite Us. Be sure to put in the note, this is a MIECHV case, so that it gets expedited.
I think similar if you do an online submission or fax it, if there's a place to put a note, please note that it's MIECHV.
That's right.
Yeah, I wasn't sure if we have access to NIDAS as well. I thought, oh, we're still doing that. Okay, so a referral, just an email to her. I think that's the way we're communicating with her. Okay, thank you.
Yeah, great question. And again, they're going to be at the learning session and cover this in more detail. So if you feel comfortable, I'll repeat that question for you if you don't get to it first, but I'd love for them to comment on that. Child development referrals. We are still tracking all the historic referrals from the innovation project. So this was in the report to the extent that you'd like to know. The 70 Sooner Start referrals came through during our active innovation period. 66 of those became active cases. That doesn't mean they were actually served by Sooner Start. It means that they took the initial step of accepting it and then moving forward to determine eligibility and possibly do an intake. Of those original 70, 59 are closed. So we're tracking the remainder there just to see what happens. And this is where our initial foray into let's get in the system and see what ETO tells us just by itself in the structured and the unstructured data. We're looking really closely at these historic innovation referrals to see how much of that information exists. I got ahead of myself, but as I said, timing is something that we want to put under the microscope in this sustainment period. It was one of the things we were dissatisfied in being able to track well, even with Unitas. Unitas was definitely an improvement there, but we still feel like this is such an important topic, right? And how long does it take for these referrals to be completed? We want to explore strategically, at least, how can that improvement be made? So identify where the gaps are, use some case examples, some prototypical examples, and then try to strategize how we might be able to improve that communication loop on timing. Similarly with the closure, just understanding when cases are closed, why they're closed. You're going to hear from us every month. So Elizabeth or I or others from the group will report out what we have learned each month. Will we be working more than likely with one agency at a time? So we're just going to round robin it, go around working with each of you. When we're working with your agency, again, we're going to try to lean on our rounding calls to gather some information. So we may jump on one of your rounding calls, show you some of these dashboards and information that we've learned, and then get your input on whether we're interpreting it correctly. We do want to, and I don't know if I put this on here or not, but we do want to meet with clients who've gone through a referral journey this year, just as we had done during the innovation project, as a checkup on the fluidity of the user friendliness of that process. So we did the same thing during the innovation. Largely, the responses we received were positive, although they definitely identified some areas for improvement. And we want to hear from them again, especially now that the innovation project is in the rearview mirror, as is our Unitas system. Okay, I think I've covered everything else that's on the slide here. And that is the last slide. So we've got 10 minutes to spare. Let me go off of screen share. Any questions, comments about the content from today, or maybe about the learning session next month, about your PDSAs?
Just maybe to consider just to have learning sessions like we used to in Oklahoma and some in Tulsa, that way the folks that are more in that area just to do it close to Tulsa, and then the ones in Oklahoma, just because we have providers that have small children, and the same is for Tulsa coming over here. So it's the same situation, just makes it a little bit complex when you have, children that need to be picked up, and maybe you don't have other supports and you're the only one that does it. So just to, I don't know, consider next learning collaboratives to have more, like we used to, one in Tulsa, one in Oklahoma City. That will help. I know that a lot of my staff has gone like, oh my gosh, I mean that the arrangement they have to do, and asking if what time we're gonna finish. So if we can finish a little earlier, not all the way to 4:30, that will help.
I appreciate the feedback on that. Thank you, Patty. Take it under strong consideration. And yes, we're trying to reacclimate to the idea of being in person. We really liked the energy and the productive nature of the one we held 6 months ago. So definitely do not want to abandon the in-person. We were always torn when we had it split between Oklahoma County and Tulsa County because one side didn't get to hear from the other. And that was never ideal. But yeah, logistically, I realize it's not easy.
Yeah, in our case, I mean, we knew with time, you know that I had to ask for a draft agenda and everything because, I mean, with Oklahoma City Public Schools, if we leave the city, we have different, I mean, we have tons of forms. It needs the signature, maybe, you know, the director and, I mean, up and up. And I was, you know, try to get with our financial person to make sure that we have the money to travel. But even if we had the money to travel, it was another step and another form and another signature. And so it was, and again, I understand that the way that when we all got together, we have a lot of more input and, you know, but yeah, like Patty said, there is some obstacles also that we have to face.
Yeah, thank you, Yolanda. You know, best laid plans don't always work out the way you had hoped. So we wanted to be equitable to the Tulsa folks who came to Oklahoma County last time. But yes, I hadn't thought about, you know, everybody's sort of under funding restrictions. We certainly are, and that's making things like travel a lot harder than it used to be even just a few months ago. So anyway, yeah, thank you for the alert on that. I hope what we turned around was sufficient, and you guys are going to be able to join us. And we will take under strong advisement, and um, we'll meet with health department folks, many of whom are on the call now, and come up with a game plan for the next learning session that is more accommodating.
Another question that I had, I mean, I have a combination of staff of MIECHV and non-MIECHV, but some of the non-MIECHV was asking me if they had to attend. I mean, they're not MIECHV, they're part of the project, but they're not MIECHV staff.
Gotcha. Yeah, we would like for them to be there. We think that this topic would benefit all. We would hate for their voice to not be included. I have to defer that one, I think, to the health department colleagues as the awardee. And I don't know if the right people are on the call and may not want to make a in the moment decision on that. So can I get back to you on that, Patty and others?
Yes, thank you.
Any other feedback? Well, I like the fact that we know each other well enough that we can have those hard conversations. And I'm sorry to put you in a pickle for next month. If it was feasible, I think we would try to make alterations now. But what we can promise to do, as I said, take it under strong consideration, try to find the resources to make that happen for the next one. Okay, well, we appreciate your time. We're really looking forward to seeing you next month, and also seeing the fruits of your labor come through in the rounding sessions that are going to be scheduled in the next couple of weeks. So onward and upward, and see you late May.
Thank you.